Oncofertility is a term that's bridging cancer care as well as fertility. We know that the very medications that help cure patients with cancer can also have detrimental effects on fertility. When patients are cured from their cancer, it may become more difficult to become pregnant. Oncofertility as a term was coined here at Northwestern, and we basically discussed three main forms of fertility preservation. We talked to them about egg or embryo freezing, which involves the first half of an IVF cycle, so 8 to 14 days of self-administered injection hormones, during which time patients come in for monitoring about 5 to 9 times, followed by an egg retrieval done under anesthesia. Following the egg retrieval, those eggs can either be frozen or exposed to sperm. So the second non-experimental option is something called ovarian tissue cryopreservation. This involves surgical removal of an ovary and the freezing of the outside portion of the ovary, where the eggs are. And so the idea here is to freeze where the eggs are stored, and then once the patient is cancer-free, that tissue can be retransferred into the body and eventually will start producing hormones. It is one of the few options that's available for prepubertal girls. The third option is a GnRH agonist. So this involves placing a patient on a medication that can induce a temporary menopause. The idea here is that if the ovary is menopausal, then the chemotherapy, which would attack rapidly dividing cells, would not be attacking the ovary as dramatically. What we know is that there is some promise in certain cancers, including breast cancer, but it's less promising in certain other cancers, including leukemias and lymphomas. And so this is currently considered an experimental option. The best option is really an individualized patient decision. Not all treatments would be detrimental to the ovary. So the good thing is that fertility preservation planning can be done very quickly. The whole process takes about 2 weeks of time, and studies done have really shown no detrimental impact in terms of mortality or cancer recurrence by taking that short time to do fertility preservation. So it's really exciting to be a reproductive endocrinologist during these times. It can be both challenging and exciting, but I do think that our field is really emerging, and we are further understanding ovarian aging, as well as the effect of certain chemotherapies and biologics on the ovary. It's always an area of interest and active research. I love every aspect of what I do. I see patients with infertility. I do a lot of hysteroscopy procedures. I see patients for fertility preservation, both planned fertility preservation as well as in the setting of cancer. It's just extremely gratifying to see patients who are struggling and then finally succeed, or who are even struggling and then ultimately don't succeed, but at least have some closure.